What's up, everybody? My name is Justin. I'm about to drop some knowledge on what meningitis is, so I hope you guys are just ready to learn, especially after being in a semester of nursing school, after Thanksgiving break, after eating turkey, and just waiting for winter break. I hope your guys' minds are ready to learn about what meningitis is. So first off, meningitis rhymes with elephantitis, but that is neither here nor there. Meningitis is an acute inflammation of the meningeal tissues that surround the brain and spinal cord. This disease usually occurs more often in the fall, winter, and spring, and usually this is just based off of because of weather. People are indoors more often, and people are more close encounters with others, but we'll get to that here shortly in this presentation. So bacterial meningitis is primarily caused by Streptococcus pneumonia and Neisseria meningitis. Don't quote me on that. I don't know how to pronounce that correctly. These organisms gain entry to the CNS through multiple routes, either upper respiratory tract or the bloodstream. They may also enter directly through penetrating wounds of the skull and or fractural sinuses. So don't break your face. The inflammatory response increases cerebral spinal fluid production, causing the purulent secretions to spread quickly to the cranial nerves and intracranial structures. Complications could lead to cerebral edema and increased intracranial pressure. Those at risk for this disease, high at risk, are people who spend a lot of time close encounters such as dormitories, so students, maybe people in prisons, people at basic training, anywhere of that nature where people are going to be in close contact for long periods of time. Also, older adults and rehabilitated persons are at risk due to lack of mobility and suppressed immune system. Some key clinical manifestations of this disease are fever, severe headache, nausea, vomiting, and nuchal rigidity, which is Steph rigidness. You know how you feel after when you're about to take a test? Some nuchal rigidity going on. And other signs like photophobia, decreased level of consciousness, also skin rash, petechia, and increased intracranial pressure, which also can be indicated by a delayed pupil response or dilated pupils. So some potential nursing diagnoses following meningitis include, but are not limited to, decreased intracranial adaptive capacity related to decreased cerebral perfusion or intracranial pressure, hyperthermia related to infection and abnormal temperature regulation by the hypothalamus, acute pain related to headache and muscle aches, acute confusion related to impaired cerebral edema or impaired cerebral function, impaired physical mobility related to central nervous system insult. They're also at risk for ineffective cerebral tissue perfusion related to reduction of blood flow and cerebral edema. Risk for disuse syndrome related to altered level of consciousness, immobility, and altered nutritional intake. Risk for injury related to disorientation or seizure activity. One potential complication following meningitis would be increased intracranial pressure related to an increased cerebral spinal fluid production and swelling around the dura. So ways to identify this potential complication is to observe for change in level of consciousness, which would be resulted from impaired cerebral blood flow. Look for changes in vital signs due to increased pressure on the thalamus. Also, ocular signs due to brain shifting from midline and or compression. So you're going to be looking for dilation of pupils, sluggish or no response to light, inability to move the eye upward, ptosis of the eyelid, decrease in motor function, headache, vomiting not preceded by nausea, or projectile vomiting related to pressure changes in the cranium. So you know what happens after vomiting? Gotta get those fluids back. Ways to prevent this complication of increased intracranial pressure is early identification of the meningitis infection, initiation of antibiotic therapy, ICP intracranial pressure monitoring with ventricular ostomy or fiberoptic catheter. So you're going to want to monitor the intensity of the intracranial pressure. Administration of drug therapy to minimize ICP, such as diuretics to help get the fluids out of there. I believe like a hypertonic solution to help draw the fluid from the cells into the bloodstream, lowering the pressure. Corticosteroids will help decrease inflammation. Antipyretic, which will decrease fevers, which increases with intracranial pressure. Barbiturates decrease cerebral metabolism. And yes, IV hypertonic saline solution. So massive movement of water out of edematous swollen brain cells into the blood vessels, so that's going to help decrease the amount of fluid within the cells. You're going to want to keep the head of the bed elevated to at least 30 degrees. Definitely don't want them bending over or laying back, because that's going to cause more blood flow to the brain, which will increase pressure. Have the patient be mindful to turn slowly and make gentle movements, because rapid change in position can increase intracranial pressure. You want to avoid extreme hip flexion, which this will put you at risk for raising intra-abdominal pressure. You want to make sure to turn your patient every 2 hours if they are immobile to avoid bed sores. Prevent discomfort and pain with analgesics, which is very important in pain management. Minimize agitation with sedatives as ordered, keeping the lighting a little low, quiet environment. Minimize physiologic factors that increase intracranial pressure, such as the Valsalva maneuver, which is basically what we do when we try to pop our nose, like that. Yeah, don't do that, because that increases pressure into the brain. Coughing and sneezing are also things to increase intracranial pressure. Suctioning, and also when you are aroused from sleep, usually when they get up or anything like that, that might cause a head rush. It's going to cause an increase in intracranial pressure. So those are some things to observe and monitor. Another potential complication following meningitis may be seizure activity related to cerebral irritation. Identification of this complication involves jerky movements. I did not mean to offend anybody, just trying to imitate a seizure. So you want to keep the side rails up and padded on the bed to prevent falls and further injury. You want to monitor for seizure activity so that interventions can be initiated. Also, airway, breathing, circulation. So when they're seizing, just try to keep that airway good, keep them on their side. Ways to prevent this is to administer sedatives, such as anti-seizure drugs. You also want to keep fluid management, manage fluids, reduce risk of seizure so seizures are less likely to happen when your electrolytes are imbalanced, such as sodium. If those are out of whack, then some complications can follow. So you want to also prevent the underlying cause, or treat the underlying cause, which is the inflammation. So treatment of corticosteroids, IV antibiotics to get rid of that bacteria causing the inflammation. You want to stabilize the body temperature to minimize febrile seizures, which are seizures caused by fever. Another complication is Waterhouse-Friderichsen syndrome, related to seizure bacterial infection, which is the meningococcal meningitis. So identification of this would be petechia, an adrenal hemorrhage, and extremely low blood pressure, tachycardia, which is indicative of shock, so that's not good. So ways to prevent this are early identification of the infection, antibiotic therapy in a timely manner. Okay. So last but not least, some specific lab results that might be indicative of this disease. You're going to want to take a blood culture. If the blood culture is positive, that indicates an infection. And then you would follow up with a CT scan and a CSF, cerebral spinal fluid test, for verification of meningitis. So the CT scan is used to rule out an obstruction of the foramen magnum. If it's negative, that indicates that there is no obstruction. After obstruction is ruled out, a cerebral spinal fluid analysis is required, and a positive result would indicate an obstruction. And if an obstruction is indicated, then meningitis would not be the cause. A negative cerebral spinal fluid test indicates no bacterial infection, and positive results indicate the possibility of two types of infection sources, bacterial or viral. If a gram stain is positive, then bacterial meningitis is the cause. If it is negative, bacterial meningitis is not the cause. Viral meningitis would be suspected. Protein levels of the cerebral spinal fluid are indicative of what is the cause of the infection. High protein means bacterial cause, low protein means viral cause. If your cerebral spinal fluid is purulent and turbid, it is most likely a bacterial source. If it is clear, most likely a viral source. A head x-ray can also be in addition to these testing to help rule out any causes. So for treatment, bacterial meningitis is a heavy antibiotic therapy such as ampicillin, penicillin, vancomycin, cefotaxime, centrovoxome, and there's a few other antibiotics that I can't pronounce, but dexamethasone may also be prescribed in conjunction with antibiotics to help reduce systemic swelling. Viral meningitis, you're going to be treating, it's going to be managed symptomatically without medications, as viral meningitis is self-limiting. Prevention is the best treatment, and vaccinations are recommended for specific age groups and those of a higher risk for viral meningitis, such as college students living in dormitories. So just any other collaborative care, you're going to want to make sure that the patient receives rest, adequate rest, allowing them to heal, IV fluids, making sure they're getting the fluids that they need, as well as the electrolytes. Hypothermia, temperature reduction minimizes the ability of bacteria to cause further infections and slows their progression. If you guys have any questions, feel free to email me at jbernal13@cnm.edu. If you guys want a copy of this outline too, just email me at jbernal13@cnm.edu. And really amping just to hit the slopes. So good luck on your guys' finals week, and thank you for your time, and I hope this presentation was helpful to you guys. Keep it up and keep up the good work.